Hello, this is Eric Strong from Stanford University and Strong Medicine. Today, I'll be discussing an approach to altered mental status, focusing on acutely altered mental status. The first thing to discuss is the fact that the term altered mental status is imprecise and should generally be avoided when describing patients to colleagues and in documentation. The reason that is in common usage within medical settings, the term altered mental status is used as a label for quite distinct clinical syndromes with different causes and different treatments. These distinct syndromes can be differentiated from one another based on several key characteristics. One characteristic is wakefulness, or how awake or arousable the patient is. Another is alertness, which is a qualitative assessment of whether the patient can demonstrate an awareness of themselves and of others around them. In most circumstances, consciousness requires both wakefulness and alertness. So a person whose eyes are open but staring at the ceiling without being able to respond to others, they might be considered awake, but in almost all circumstances, not conscious. This is what's seen with patients experiencing what's called a persistent vegetative state. Now, there are certainly rare exceptions to this, such as the locked-in syndrome, that I'll come back to in a few minutes. But generally speaking, to say a patient is conscious, they must demonstrate purposeful movement or thought, or at least react in some way to the external world, such as responding to someone's voice, reaching for an object, or even just tracking another person's movement with their eyes as that other person walks across the room. Another characteristic to assess is attention. This describes how well a person can stay on task. Some quick bedside tests of attention include the ability to follow a 3-step command, or reciting either the days of the week or months of the year backwards. One that's less commonly done, but which I personally like, is to have the patient either raise their hand or squeeze the examiner's hand every time a specific letter is said during a recitation of random letters. 3 other key characteristics are orientation, thought process, and thought content. Orientation is whether the patient can state where they are, what the date is, and what the current situation is. For example, being able to state that they were brought to the ER by their family because they had a fever. A patient's thought process refers to the relevance, organization, and coherence of their thoughts. For example, whether the patient can stay focused when answering a question, or they kind of veer off into an irrelevant but still relatively coherent tangent, or is jumping so quickly from one thought to the next that you can't follow anything they're saying. Thought content includes the presence of hallucinations and delusions. The first 2 of these characteristics on this list can be framed as the level of consciousness, to contrast that with the last 3 being the content of consciousness. Attention does not neatly fall into either one. These characteristics are not fully independent of each other. As just one example, a patient experiencing decreased wakefulness may find it difficult to remain oriented to time, since the passage of time is difficult to gauge when one is extremely drowsy. The last key characteristic that differentiates syndromes of altered mentation is the temporal pattern. For example, are abnormalities fluctuating from one hour to the next, or are they consistent across time? Now, let's look at the specific syndromes. The first is delirium. The hallmarks of delirium are impairments of orientation, thought process, and thought content, as well as a fluctuating course. So in the morning, a patient might not be able to state where they are or an approximate date, and then in the afternoon, they might be fully aware of both those things, but answers to more complex questions are not clear or linear, and then at night they are disoriented again, perhaps now with some visual hallucinations or a delusion that the nurses are trying to kill them. How the patient looks and acts at the bedside is changing throughout the day. Patients with delirium always have impaired attention, but their level of wakefulness and alertness can be reduced, normal, or even higher than normal. Delirium with reduced wakefulness and alertness is called hypoactive delirium, while that with increased wakefulness is predictably called hyperactive delirium, often with increased psychomotor activity, such as wandering at night or combative behavior. As a general rule, hypoactive delirium is more difficult to identify than hyperactive delirium and is frequently misidentified as dementia, depression, or as the next syndrome, somnolence. The hallmark of somnolence, sometimes imprecisely referred to as decreased mental status, is that wakefulness, alertness, and attention are all reduced. However, unlike hypoactive delirium, the patient is non-fluctuating or consistent. Orientation may be impaired depending on severity and etiology, but thought process and content are usually normal. Patients with a somnolent subtype of altered mental status do not hallucinate or have delusions about their situation. The last subtype is one of agitation and psychosis, keeping in mind that these two terms are not synonyms, but they have enough shared features to consider them one relatively broad syndrome. In this case, wakefulness and alertness are always increased, what is referred to as hyperarousal. There is also increased psychomotor activity, such as pacing around the room or ward, and speaking more quickly than normal. Attention is usually reduced. Orientation, thought process, and thought content can all be either normal or impaired. The use of the term psychosis rather than agitation specifically implies the patient is experiencing prominent hallucinations, delusions, and/or disorganized thought, such as incoherent rambling. In most contexts, the use of the word psychosis does not imply that the patient necessarily has an underlying primary psychiatric disease. The pattern of abnormalities in states of agitation and psychosis can be either fluctuating or consistent depending on the underlying cause. As you may have already noticed, there may be relatively little clinical distinction between hyperactive delirium and a fluctuating psychosis. One can graph these three syndromes by looking at the level of consciousness versus the content of consciousness. Somnolence has decreased level of consciousness with a content of consciousness that can be either normal or modestly impaired. Agitation and psychosis have impaired content of consciousness, but with a normal or even higher than normal level of consciousness. With delirium, hypoactive delirium can look similar to somnolence, particularly if the patient is only examined at a single point in time, while as mentioned, hyperactive delirium can look similar to agitation and psychosis. There is a frequent comparison made in textbooks and medical school lectures between delirium and dementia. In delirium, the onset is acute to subacute, roughly meaning over hours to a week or so, while in dementia, the onset is chronically progressive over months to years, though sometimes with stepwise declines in level of functioning, typically following acute medical illnesses. Signs in delirium fluctuate over time, while they are relatively consistent in dementia. Finally, delirium is usually reversible, while dementia is irreversible. Importantly, while pure delirium is easy to distinguish from pure dementia, the two are not mutually exclusive, and a common diagnostic challenge is determining whether just one or both are present, a distinction which almost always requires collateral information from someone who knows the patient outside of the healthcare setting. The presence of pre-existing dementia also increases the risk of developing delirium when additional pathology is introduced. For example, when a patient with dementia has a urinary tract infection or is started on steroids. Developing a diagnostic framework for syndromes of altered mentation is tricky because the three primary syndromes have overlapping but not identical lists of etiologies. However, they generally map to the same broad categories. An easy way to remember these categories is with a mnemonic I first saw on the excellent Clinical Problem Solvers website, MIST. M for metabolic, I for infection, S for structural, meaning a physical problem in the brain, usually a space-occupying lesion, and T for toxin, though toxin also includes medications. In addition, there is a long list of miscellaneous causes which don't fall neatly into one of these four categories. Before doing a deep dive into each category of pathology, we can first make some generalizations about which categories tend to cause which syndromes. The most common causes of delirium tend to be infections, sedative withdrawal, and from the miscellaneous category, hospital-acquired delirium. The most common causes of somnolence are metabolic, CNS infections, any cause of increased intracranial pressure, and either sedative intoxication or stimulant withdrawal. And the most common causes of agitation and psychosis are CNS infections, steroids, stimulant and hallucinogen intoxication, and sedative withdrawal. And also causing agitation and psychosis are, of course, primary psychiatric disease, such as schizophrenia and the mania of bipolar disease. Now, let's talk about the etiologies more specifically, and it is a long list. It's probably the largest and most diverse diagnostic framework in medicine. Starting with the metabolic category, we have electrolytes, which includes derangements of sodium, calcium, glucose, and pH, as well as hypercapnia, or high partial pressure of carbon dioxide. Isolated derangements of potassium and low PCO2 are not notable causes of altered mentation. Other metabolic causes include hypoxemia, shock from any cause, liver and renal failure known as hepatic encephalopathy and uremic encephalopathy respectively. Wernicke's encephalopathy is a condition caused by thiamine deficiency, which classically presents with a triad of confusion, unstable gait, and ocular motor pathologies such as nystagmus. It's most often observed in patients with chronic heavy alcohol use. Thyroid disease, either hypo or hyperthyroidism, can cause altered mentation, though the form of altered mentation looks very different between those two, with severe hypothyroidism causing depression, fatigue, and somnolence, while hyperthyroidism can cause anxiety and agitation. Severe adrenal insufficiency is also associated with a variety of cognitive and psychiatric manifestations. The next broad category is infection. These can be subdivided into infections of the central nervous system, such as meningitis, which is an infection of the protective membranes surrounding the brain and spinal cord, and encephalitis, which is an infection of the brain itself, and non-CNS infections, which most commonly include pneumonia, urinary tract infections, and bacteremia, though any infection, if severe enough, can cause delirium. Structural causes of altered mentation include ischemic stroke, intracranial hemorrhage, which can be epidural, subdural, subarachnoid, intraparenchymal, or intraventricular, and masses like tumors and abscesses. And then there are the so-called toxins, such as many medications, which can cause altered mentation, particularly in the elderly or when taken in combination, a situation known as polypharmacy. A non-comprehensive list of the most common culprit medication classes include both opiate and non-opiate pain medications. Among the more common non-opiate pain meds to cause confusion are tramadol and gabapentin. Other meds include steroids, anticholinergics, antihistamines, antipsychotics, which are specifically associated with the life-threatening condition neuroleptic malignant syndrome, benzodiazepines, and related sedative hypnotic drugs like Ambien, and muscle relaxants like cyclobenzaprine and baclofen. Valproic acid is associated with hyperammonemia, which can lead to altered mentation, and an increasing recognized phenomenon of cefepime-induced neurotoxicity, which is most often seen in patients with concurrent renal dysfunction. Just about any true toxin can cause altered mentation, most notably alcohol, illicit drugs, toxic alcohols like methanol and ethylene glycol, and carbon monoxide poisoning. Last in this category is a potentially life-threatening condition called serotonin syndrome, which is the consequence of either medications or illicit drugs that increase the activity of serotonin in the brain, particularly antidepressants, amphetamines, and ecstasy, and particularly when such substances are used in combination. Serotonin syndrome presents with a combination of autonomic dysfunction, neuromuscular excitation, and altered mental status. As mentioned, there are many other etiologies which don't fall neatly into the missed mnemonic, and which I'm going to place into a miscellaneous category. The most common condition in this category is, as mentioned a few minutes ago, hospital-acquired delirium, which is a form of delirium that occurs in hospitalized patients, thought secondary to a combination of acute illness, uncontrolled pain, disrupted sleep-wake cycles, side effects from new medications, and in some cases, sensory deprivation. For example, when a patient who normally wears glasses or contact lenses, or a hearing impaired patient who normally uses a hearing aid does not have access to those devices. Emergence delirium is a short-lived period of confusion, agitation, and disinhibition that can occur in a patient during the transition from general anesthesia to full wakefulness, typically seen in the post-anesthesia care unit. There is also an entity called post-operative cognitive dysfunction, manifesting primarily as relatively subtle memory deficits, most common after cardiac surgery, and which can last for several months. Other miscellaneous causes include psychiatric disease, such as inadequately controlled schizophrenia, bipolar disorder, or catatonia. Patients will often be confused for a brief period of time following a generalized seizure, something called the post-ictal state. Patients can also have a condition called non-convulsive status epilepticus, in which they are experiencing extremely frequent or even continuous seizures, but for some reason they are not physically convulsing their muscles, so the seizure is not externally apparent. Autoimmune disease can include autoimmune encephalitis, including paraneoplastic encephalitis, a condition called Hashimoto's encephalopathy, which is associated with thyroid disease, but which has a distinct pathogenesis, lupus, and isolated CNS vasculitis. Wilson's disease, a genetic disease of copper overload, classically causes a combination of liver failure and a variety of neuropsychiatric abnormalities. The similar diseases of hypertensive encephalopathy and the posterior reversible encephalopathy syndrome, heat stroke and hypothermia, and a condition called transient global amnesia, in which, as the term implies, an individual experiences a brief, total, or near total loss of memory without other significant cognitive changes, and without an identifiable cause. The condition will typically last less than a day before gradually improving. Its pathogenesis is unknown. The last category in this extensive framework to discuss are the mimics of acutely altered mentation. The first in this category is a phenomenon called sundowning. Now, sundowning is the commonly observed worsening of dementia symptoms in the evening, particularly behavioral disturbances. Although sundowning is an alteration from the patient's condition and behavior as compared to the daytime, I include it as an AMS mimic because it's not an alteration from the patient's longitudinal baseline, and it's not due to any additional pathology beyond the underlying dementia. However, distinguishing sundowning from a new acute delirium in a newly admitted patient with dementia is very challenging, unless there is a family member at the bedside who can clarify whether the observed behavior is or is not typical for that patient when they are at home or wherever residential facility they typically stay. The remaining conditions in this category of AMS mimics are those in which the patients appear to be confused, delirious, or somnolent when their higher cognitive function is mostly or completely intact. This includes dysarthria, in which there is an impairment in the tongue, lips, and oropharynx's ability to phonate words. Aphasia is an impairment of language which can be mistaken for confusion, particularly the subtype of Wernicke's aphasia, not to be confused with Wernicke's encephalopathy. In Wernicke's aphasia, speech has normal speed and cadence, but is composed of seemingly nonsense words or words that just don't make sense together. This can be distinguished from other disorders because patients with isolated Wernicke's aphasia will display normal cognitive function with any task or behavior that does not involve language. Locked-in syndrome, which was mentioned at the beginning of the video, is a horrific condition in which damage to the lower brain and/or brainstem leaves a patient with virtually no voluntary control of their muscles aside from eye movement, but with fully intact level and content of consciousness. And finally, the last altered mentation mimic is malingering, meaning the patient is deliberately faking their condition for secondary gain, such as having a warm place to sleep or avoiding jail. When it comes to which of these many etiologies are among the most common, as previously mentioned, it depends on which subtype of alteration we're considering. Among hospitalized adults in the US, common causes of delirium are non-CNS infections, a large variety of medications, alcohol withdrawal, various illicit drugs, and hospital-acquired delirium. Common causes of somnolence are hyperglycemia, hypercapnia, shock, liver failure, intracranial hemorrhage, opiates, alcohol intoxication, and various illicit drugs. And common causes of agitation and psychosis are hypoxemia, steroids, alcohol withdrawal, various illicit drugs, schizophrenia, and mania. There are two big challenges with evaluating a patient presenting with some form of altered mentation. The first, as you just saw, the diagnostic framework is huge, and it includes conditions that span from the relatively benign, like UTIs and Benadryl toxicity, to imminently life-threatening problems like meningitis and intracranial hemorrhage. The second challenge is that obtaining a reliable history directly from the patient is not possible, and particularly when the patient is hyperactive or agitated, a physical exam may be more difficult and limited than normal. So there is necessarily a greater reliance on labs and imaging to narrow down the differential diagnosis for patients presenting with altered mental status than there is for most other symptoms. And even imaging can be impossible without sedation for the agitated patient. Other unusually important components of the evaluation of the altered patient are reviewing the patient's past medical chart, if it's available, and obtaining collateral history, meaning history about the patient given to you by the patient's family, friends, or neighbors. So what are the critical features of the history that you should attempt to obtain? The first is the time course of the altered mentation, meaning how long has this been going on for? Did the changes happen all at once? Or did it progressively worsen over time? And are the symptoms consistent or fluctuating? Are there concurrent symptoms such as fever and chills, cough, dyspnea, dysuria, neck pain or neck stiffness, headache or nausea? What's the patient's past medical history? For example, do they have a history of diabetes, liver or renal disease, a seizure disorder, or dementia? Their past psychiatric history, a medication and substance use history are both critically important. And do they have risk factors for delirium specifically? In addition to dementia, these risk factors include acute medical illness, sensory impairment, sleep deprivation, immobility, malnutrition, and inadequate treatment of pain. Regarding the exam, presentations of acutely altered mental status are among the few in which a complete head-to-toe exam is truly indicated for as much as the patient is able to cooperate. Key lab tests in the evaluation include serum glucose, a complete metabolic panel and blood count, a urinalysis and urine culture, blood cultures in most circumstances, and a urine tox screen and blood alcohol level in most circumstances. Depending on the results of the above, one can consider a TSH, lactate, ammonia, and a blood gas. Regarding the interpretation of a modestly abnormal TSH, you'll need to keep in mind that TSH can be affected by acute non-thyroidal illness. And regarding the blood gas, usually a venous gas is sufficient unless carbon monoxide poisoning is suspected, in which case co-oximetry is the appropriate test. Other tests commonly used in the evaluation of states of altered mentation include a chest X-ray if pneumonia is a possibility, brain imaging, usually starting with a non-contrast head CT. Lumbar puncture is also sometimes done if the workup, including imaging, is unrevealing. In addition to all this, there are several scales and scoring systems that are frequently discussed when evaluating patients with altered mentation. One is the Richmond Agitation Sedation Scale, which is a 10-point scale ranging from +4 for combative patients who are imminently dangerous to the healthcare staff to -5 for patients who are completely unarousable to voice or physical stimulation. The Glasgow Coma Scale grades 3 behaviors, eye-opening, verbal response, and motor response, to come up with a number ranging from 3 for a fully comatose patient to 15 for normal cognition. The GCS provides information about prognosis and in some cases can guide decisions about intubation of patients with acute neurologic impairment. However, in isolation, it provides no useful information about diagnosis. In addition to these previous scales, there are a number of other scored cognitive assessments that are sometimes used in this context, including the Montreal Cognitive Assessment, or MoCA, the Mini Mental State Exam, or MMSE, and the so-called Mini-Cog. However, these tests are not appropriate for the assessment of acutely altered mental status in hospitalized patients. Instead, their proper use is primarily to screen for and grade the severity of dementia and other forms of chronic cognitive impairment in the outpatient setting. Once again, do not perform MoCAs or mini mental exams in patients in the ER or hospital. Now, when it comes to a diagnostic algorithm for acute mental status, despite the different subtypes with different lists of etiologies, the initial steps to determining a diagnosis are remarkably similar. Let's take a look. Before even starting the history, there are a few very time-sensitive things to address first. Assess the ABCs, that is, the patient's airway, breathing, or the presence, frequency, and depth of respirations, and circulation, that is, the pulse and blood pressure. Immobilize the spine if there's a history of trauma. Because it's so fast to check and hypoglycemia is imminently life-threatening, check the serum glucose with a glucometer, even if the patient is not known to be a diabetic. If heavy alcohol use is suspected, empiric thiamine for treatment of Wernicke's encephalopathy, which can acutely worsen if glucose is given in the absence of thiamine. And if the patient is somnolent and has a low respiratory rate, give empiric naloxone to reverse possible opiate overdose and consider intubation. Once those things are completed, then proceed with a more thorough evaluation, including history and exam, a complete metabolic panel, blood count, blood gas, blood cultures, UA and urine culture, urine tox screen, alcohol level, and serum drug levels of any of the patient's prescribed medications, though this is not readily available for most meds. A chest X-ray can reveal pneumonia, and a non-contrast head CT should be performed unless the diagnosis is already readily apparent from the above. For most patients, this set of data will already establish or strongly suggest a specific etiology, in which case continue with a focused evaluation of that etiology and initiate treatment. On the other hand, if the etiology is not yet established, ask if a lumbar puncture is indicated. Considerations here include whether there is a fever, the patient has a headache, unexplained leukocytosis, meningeal signs on exam like neck stiffness, and if the patient is immunocompromised. If enough of these considerations point towards LP, then do one. If the etiology is established or suggested, great. But if either an LP is not indicated or the LP was non-diagnostic, then you should continue to the next set of diagnostic tests, which can include a TSH, ammonia level, thiamine level, though this test is not particularly sensitive for Wernicke's encephalopathy, and a serum osmolarity to identify the ingestion of toxic alcohols, keeping in mind that serum osmolarity is best run on the first blood sample following presentation rather than on a blood sample from many hours later. Depending on circumstances, one can consider a brain MRI, EEG, and either a morning cortisol or court stim test to identify adrenal insufficiency. If an etiology is still not established and the patient has not yet spontaneously improved, which does happen sometimes, you're moving into rare etiology territory. You should perform an LP if not already done, and consider looking for paraneoplastic disease, autoimmune disease, Wilson's disease, and causes of rapidly progressive dementia. And when I say consider these rare diagnoses, that's what I mean. You don't necessarily need to test for them if the data you've already obtained is clearly inconsistent with them. However, in particular, I would think about paraneoplastic encephalitis, in which the primary tumor underlying the disease is not yet otherwise clinically evident. Although paraneoplastic encephalitis is rare, among patients ultimately diagnosed with it, it is common for the neurocognitive findings to have preceded the cancer diagnosis. The key takeaway points for this video: altered mental status is an imprecise term that should be avoided in favor of delirium, somnolence, agitation, or psychosis. The altered mental status syndromes can be distinguished by level of consciousness, content of consciousness, and their temporal pattern. Delirium, somnolence, agitation, and psychosis all have broad, modestly overlapping diagnostic frameworks, but medications, alcohol, and illicit drugs are shared common causes. And last, the history and physical exam, conventional labs, and head CT will identify the majority of etiologies. If these are insufficient, lumbar puncture, brain MRI, EEG, and more specialized blood tests may be indicated. Thanks for watching this video on an approach to altered mental status. If you found it helpful, please consider subscribing to the channel and checking out the rest of this series on an approach to symptoms.